Great, thanks very much, Claire, for that nice introduction. So I think I probably wrote myself, to be fair. So, picking myself up a bit too much. So I'm just here to talk today about some new developments in obstetric anaesthesia. I did have a little look at the literature before I decided on what to talk about, but these are things that I find particularly interesting. So it's kind of a personal view of stuff. The things I'm going to talk about are programmed intermittent bolus and patient-controlled epidural analgesia, apneic oxygenation, and a little bit about enhanced recovery for obstetric surgery. I apologise if you're all a bit sick to death of enhanced recovery, but there's a couple of new things out there as well. So, programmed intermittent bolus and patient-controlled epidural analgesia. So what's that all about then? Well, this is a study done I wish I'd thought of doing this actually, because all they did was they put the end of an epidural on some blotting paper and ran it according to an infusion at the top or bolus at the bottom, where it came up with a very dodgy looking trace, to be fair. But you can see that if you just put a continuous infusion in, it just sort of sits there and doesn't spread out. I mean, it's not rocket science, is it? But if you have a bolus, and they're quite small boluses, 3.5 ml boluses, then that spreads out a lot better. So that's all very good on blotting paper. So what about in the real world? Well, there's been quite a lot of work done, as I'm sure you know, about boluses and infusions. And back in 2002, here's a meta-analysis of some of that work. Studies of 640 patients, and they found that with patient-controlled epidural analgesia compared to an infusion, there were fewer anaesthetic interventions required to make the epidural work, less local anaesthetic needed to do that, and less motor block, although both methods were safe for the mother and the baby. So just to go into that paper a little bit, here we can see intervention by anaesthetist, and you can see all of the studies virtually are to favour patient-controlled epidural analgesia, so they all favour that the anaesthetist is not required quite so much. This is dose of local anaesthetic. Differs a little bit for the different studies, but very clearly you get more bang for your bucks if you're going to give things as a bolus rather than an infusion. Now, Rachel Collis, as mentioned in the earlier talk, I've always thought a lot of respect for Rachel Collis. She's rather confusingly married to somebody called Collins, and they both keep the same name, so I always found that a bit confusing. But she's done some really fantastic work. So I've taken one of the papers out of that meta-analysis just to illustrate a few points. For this study done in 1999, they were using the same concentration as many of us do, 0.1% bupivacaine with fentanyl, 2 mics per mil. But they had 3 regimes. One was the midwife giving boluses according to the request of the woman, no more than once every 30 minutes. Another group was patient-controlled epidural analgesia with 10 ml boluses, which you could request by the button, which I think was virtually the same thing, really. Not as it turned out. And the other was just a continuous infusion of that concentration, that mixture. And all of them could be troubleshooted by giving 10 to 15 ml boluses down the epidural for breakthrough pain. And here's some of the things that are drawn out from that paper. So you can see on the right, leg weakness, if you put an infusion in, it just sort of wanders down, with the woman sitting up, it goes down into their legs where you don't particularly want it, and they gradually get heavier and heavier legs. It's just an inevitable thing. With patient-controlled epidural analgesia, where they were using a bolus, then that was not as bad. It maintained, but it still eventually went down. Whereas with the midwifery only, that was the best sort of leg mobility. This is over sort of 7 hours or so. And you can see across on the other side of the slide, the amount of local anaesthetic and fentanyl, they rather confusingly had the two divided up. I don't know whether they were giving separate boluses of bupivacaine and fentanyl outside of the protocol, but we'll leave it at that. But you can see that if you look at bupivacaine, the midwives were giving the fewest amount of local anaesthetic, whereas the continuous infusions were the most, and PCEA was between the two. And if you look at number of occasions where pain was reported, different levels of pain, they're basically the same across them all, which I think is quite interesting. There's no significant differences between them. But if you come down to the bottom and look at the number of times that the anaesthetist is called, you can see that it's called, the anaesthesia was called most for the continuous infusion. So 17 occasions once, or 17 occasions more than once. And there's quite a significant difference there. And PCA sort of sits, again, between that and the midwifery boluses. So it looks like what we should be doing is just giving them midwives a syringe and letting them get on with it. But actually, we used to do that at the Jessup wing, and the trouble with that was that with it being a controlled drug, they had to go, with two of them had to go to the cupboard all the time to get this thing out, and it was very unwieldy, and it meant that it didn't work so well. They work better in this particular unit, of course. So here's a systematic review of patient-controlled epidural analgesia from 2009, and sorry, it hasn't come across very clearly, but what I've highlighted there is high-volume, dilute local anaesthetic solutions with a continuous background infusion appear to be the most successful strategy. So in other words, it's not, not just having the woman bolusing on her own is not the best thing. We should have a background infusion. And here is a review of practice in the UK. I think it was an OAA survey. And you can see that basically that's what people are doing. So we've got bolus size. I found this quite interesting because I think a 10 ml bolus is quite big, even though they used it in that study. I feel a bit worried about a woman alone in the room. Perhaps the midwife's just gone out for a couple of minutes. She presses the button, 10 mils bolus, and I feel a bit worried about that. But my worries are unfounded because a lot of units appear to be doing that, 30% of the units. Lockout times are variable according to that. Most of them are sort of around 20-30 minutes. But on this side, you can see that almost everybody's using a background infusion of varying volumes. Okay, around half of them are using more than 10 mils an hour as a background infusion, which is quite a bit, really. So what about this programmed intermittent bolus thing? Well, what this involves is your epidural pump giving a bolus, say, on the hour, rather than giving it over an hour. So 10 mils on the hour rather than over the hour. And there are some theoretical benefits according to some research, which I'm going to show you in a little bit. But up to now, our pumps have not been able to deliver this. But I think they're becoming more widely available. Now, although those pumps weren't widely available, there's quite a bit of research, if you look into the literature, been done on this. And here's a meta-analysis from 2013, 9 randomized controlled trials. Now, the comparator group wasn't always just an infusion. It was either PCA, some of them were PCA and some of them were continuous infusions. They had quite a large number of patients in there, sort of 344. But they didn't find big benefits from it. But I'll go through the headline and go through the actual paper a little bit more detail after that. So they didn't find any difference in cesarean delivery, which isn't a big surprise. No difference in duration of labour or anaesthetic intervention, but less local anaesthetic was used, and the mothers were more satisfied, which kind of makes you wonder how they were more satisfied, doesn't it? So here we've got mode of delivery, and at the top you can see caesarean section, and you can see there's just no difference there. But if you look at the bottom, instrumental delivery, now we're giving less local anaesthetic, so there's reason to believe that the legs and perineum, etc., are not quite so numb, and loss of muscle tone. And you can see, although it wasn't significant, it almost was. Okay, so that if the summative statistic is across that side, it's just inside the one that favours the intermittent epidural bolus group. Duration of labour. Now, what they did for this side, they compared the intermittent bolus with PCA or with continuous infusion. So there's non-PCA and PCA. So if you're using an infusion, a mainly infusion-based regime, then adding in the bolus was a beneficial thing, and that seemed to work. It seemed to reduce the length of labour, although the summative statistic was not different. Anaesthetic intervention, again, slightly favouring, it didn't quite reach statistical significance, but almost did. Okay, so there are, even though the bottom line is these things are not making much difference, in fact, there is evidence it is sort of reducing certainly the amount of local anaesthetic, and possibly improving pain as well. And finally, mils per hour and maternal satisfaction. Well, they did show a reduction in mils per hour, but quite a small one. But the satisfaction is quite interesting, isn't it? They seem to be a lot more satisfied. I'm not sure why that is. I'm thinking about it. I can't think why that is. Now, the reason I'm interested in this is because we've recently introduced intermittent epidural bolus at our unit, and we didn't have to pay anything for it. We already had pumps. We just didn't have the software that went with it, and it was a bit of a faff because when we got sold the pumps, they said, "Don't worry, Dr. Inch, intermittent epidural bolus is coming to these pumps, and we just getting the software from somewhere, and get these pumps now, and that'll work just fine." And so that's great. And then when they came back to them, actually, that's a little bit more problematic, and so I had to jump up and down quite a lot and say, "Look, you promised," and eventually we've got the software upgraded. But I think the more recent version of these has got this on it already. But if you've got that sort of pump, you can get it upgraded. It doesn't cost anything. And what we did was our regime at the Jessup wing since about 2000 has been this 0.1% bupivacaine with 2 mics per mil of fentanyl for some time. And with we use 7 mil per hour background infusion with 5 mil patient-activated bolus. And what we've changed to recently is the 7 mils per hour background infusion is a 7 mil bolus. So it's a 7 mil bolus on the hour. And we've taken this as a poster to the upcoming OAA meeting. So you can see we had significantly less local anaesthetic being given. It's only a couple of mils, possibly 1.5 to 2 mils per hour. Less, but significantly different. We did find that their leg mobility was better. Which is interesting, which was more than I was expecting. I didn't think it would be quite so significant as that, but it was very significant. Percentage hours of no pain, it was only for the first 6 hours, was basically the same. There's a suggestion that the pain relief's a bit better there, but if you add in the mild pain as well, you get to something like 90% for both of the regimes. So yeah, it has been effective. And we've recently now changed, because the things that we didn't see the block height going too high. There were no more instances of when, because we checked the block height with cold spray, and there weren't any more of those in the group that had the 7 mils per hour bolus, so we felt reassured by that. And we've now changed the patient boluses to 7 mils an hour as well, and we're just looking at that data now. Okay, so what do I think about programmed intermittent bolus and PCA? I think there's some potential advantages. It does seem to give you less solution and better maternal satisfaction. Certainly that's what came out of the meta-analysis. Better pain relief, possibly. I suppose I'll just, as a personal view, I think there might not be a lot more we can do with epidurals to make them any better. That would be my personal view. I think we, particularly in obstetric anaesthesia, and I've done it myself, we tend to go off down this cul-de-sac of getting it better and better and better, and it might be that there's not going to be a lot better. The way to make it better is having a one-to-one midwife. The midwives did better, didn't they, with their syringes, rather than a clever regime. And I'm not going to be investing in some computerized stuff to change our pumps. I don't think that's the way forward, personally. I don't think it's a good idea. I think, they're as good as they're going to be, and a little tweak that's simple, that's fine, but I don't think there's much more to it. Anyway, that's the end of that. My personal view. Right, so the next thing. Apneic oxygenation is a topic that's come into the literature recently, and it has some implications for obstetric anaesthesia. I dare say you've heard of it before. Interestingly, it was first described in 1908. When you look back at your ancestors, you tend to think they're not quite as smart as us, but it turns out they are pretty smart back then. They were pretty smart back then, and they worked out that there was less carbon dioxide coming out than oxygen going in, and so if you just keep the airway open and the oxygen flows in, it'll continue to go in, it'll continue to be taken up, and that's what the sort of basis of apneic oxygenation is, that there's a concentration gradient there. Oxygen's being extracted faster than carbon dioxide is being put back in. And in fact, this has been acknowledged in the DAS guidelines recently, where they did quite a lot of, obviously quite a lot of very good, the joint guidelines with obstetrics, the OAA as well, Mary Machambi, etc. And they said, duration of apnea without degeneration can be prolonged by passive oxygenation. They recommended that it was very good in obesity, that it prolonged the period where you until your oxygen levels fell. And they mentioned particularly this Thrive, this transnasal high flow thing, and that was a good thing. But they did recommend that nasal cannulae may be good idea to use in high risk patients. But I'm going to contradict that a little bit, so you can make of that what you will. Obviously they're pretty clever people, aren't they? But I couldn't find the evidence for it so much. What are the cautions about this? Well, you need denitrogenation, so the nitrogen's got to come out there to fill your lungs with oxygen. You've got to keep that pathway patent. And if you're not careful, there's a chance of barotrauma, and you need 2 oxygen supplies. Who uses this in the room? Hands up who's been using this technique. So it's not very widely used, okay. One of the disadvantages, you can't actually assess how good your pre-oxygenation is, because you haven't got that measure of end-tidal oxygen. You can't measure it with this high-flow oxygen. And it may interfere with the mask seal. And also, if you're going to use 15 litres of oxygen up somebody's nose, that's not a pleasant experience, I don't believe. So not something I want to have done to me, I would have to say. So let's consider the nasal prongs idea first of all. Here's a paper from 1998 where they used it for fibre optic intubation. So they had these nasal prongs in or not, and then they looked at the PaO2, and they found that it had a little bit of an effect, a little bit of a benefit, and kept the PaO2 up. So that was a good thing. But there's been quite a sort of buzz about nasal prongs and 15 litres per minute up the nose in emergency medicine. And there's some very jazzy YouTube publications about it, very gee whiz. And in fact, I think if you look there, I think that's from Australia. That's the recommended way of pre-oxygenating in the emergency department in this Australian unit. Okay, now there's a little bit of research done on it, and this is a slightly complicated slide, and so I'll talk through it slowly so I don't get confused myself, basically. And so you can see that the black line it's a pre-oxygenation study, and what they did was they did standard pre-oxygenation, and then they did it with nasal prongs, or with with nasal prongs, or with the high flush button pressed, but in the presence of a break in the seal that was created. So the black line there on the other side, that is for the 15 litres per minute at the same time, is the standard pre-oxygenation. Then below that is when they created a standard leak in the mask, and you can see that the pre-oxygenation, not surprisingly, is worse. Then above that, you've got 15 litres per minute in the presence of a leak. Now you might think that's a bit silly because you wouldn't have a leak, but actually when we did a study of pre-oxygenation and said to the anaesthetist, you're pre-oxygenating this for a study, it's a pre-oxygenation study, there was a leak in 22% of the patients. So it's actually quite difficult. I think the masks today could be better, certainly. Maybe we should have the old black masks. That's right, Perver, isn't it? You're in favour of them, aren't you? We should have them back. Anyway. So you can see that if you have the high flush on, that maintains it even in the presence of a leak. So that's good. So on this side, if you're taking several deep breaths to pre-oxygenate, it's all worse then. So it's not helpful. So it does depend on, these added things do depend on the mode of pre-oxygenation that you use as well, the way that you do that. And here is this taken from the Nottingham group and John Hardman, who have a nice little computer model, which is it's interesting, but it's not the real world. But it's basically telling you there are different clinical situations that are here, and it's how the time your oxygen saturation would fall below 90 if you had a certain amount of oxygen in your pharynx. So coming along the horizontal line there is, coming up to 80% oxygen in the pharynx, 100% oxygen in the pharynx. And you've got things like the parturient is anemic, twin pregnancy, high BMI, really high BMI, sepsis, etc. But what it's telling you is you've really got to fill that pharynx with oxygen if you're going to prolong that period before the oxygen levels fall below 90. Okay, so I think it was interesting from that point of view. So what about this 15 litres per minute thing? Well, I did find this study that was done in America where they actually were using it on intensive care and just to see whether or not it was a useful thing to do. And they randomised their patients, and I'll just talk you through this next bit of the slide. They had 150 patients, which I think is a very good size study for a single unit. And they pre-oxygenated either the standard way or the standard way with 15 litres per minute going up the nose. And then they carried the 15 litres per minute going while they were intubating. But they found actually no benefit of that 15 litres. Okay, there was a difference, but it wasn't significantly different. And the episodes of saturation below 90, they weren't significantly different either. So really, it wasn't very promising in that situation. So these are emergency patients, obviously they're a bit more compromised, so you'd hope that it would be beneficial for those. But no, it wasn't beneficial. Now this, on the other hand, is a bit more promising. So Thrive, transnasal, humidified, rapid insufflation, ventilatory exchange, which is around the place a bit. We've got one in Sheffield, I think. Occasionally they extubate their neuro patients onto it, I think. And there's quite a lot been written about this. There's a CPD article. So you have this really high flow oxygen, and unlike the 15 litres, it isn't so unpleasant to have. You know, it's warmed, it's humidified, and it's certainly used for other things like supporting people in respiratory failure, that kind of thing. So there's a bit of a buzz around it, and part of that comes from this particular paper here. So this is the paper that got the prize at the association in the September meeting, and it's basically a case series, which is interesting. And when he gave the talk, there was some videos to go along with it. And they were using it basically for people with difficult airways, and they had 25 of them. So they had 25 of these difficult airways, and what they did was they put the Optiflow on, and you've got to get it going for 10 minutes. So you need 10 minutes of that to sort of build up the pharynx, because you're not sure exactly what the end tidal oxygen is at that time, because you can't measure it when that's on. And they gave them TIVA, and they had them 40 degrees head up tilt for the pre-oxygenation, and then with the TIVA they laid them down to 20 and carried it that way. They found the mean apnea time was 17 minutes. 2 patients went for 32 minutes and 65 minutes. Okay, they did pretty well. And if you look at the lowest oxygenation that they got for those patients, now they must have been breathing a real sigh of relief when they could say none of the saturations were below 90, mustn't they? Because blimey, there's just one right on the line just there. So not that I'm at all suspicious about what they did. I'm sure it was all very good. But you can see, there's no doubt about it, that you can extend the period of apnea and maintain oxygenation for a really long time. It does seem to work. And these are cases with difficult airways, and I think for a couple of them they just did the surgery without intubating them on the Thrive. Okay, so the other concern was, of course, well, while they're being oxygenated, perhaps their carbon dioxide is going up. And in fact, they had some evidence that it was going up, and it was going up like that. So I can't remember whether they did blood gases or how they actually measured it. I'm sorry. But so that doesn't look so good. But actually, theoretically, it should have been going up like that. So there's a suggestion that there's some exchange going on and carbon dioxide is coming back out again. But still, it's obviously the case that you can't just carry on indefinitely doing that, but it is buying you quite a bit more time. So, how about obstetrics? Well, there was an interesting abstract in the OAA, I think it was last year or the year before. There was a bit of criticism that it was research, but actually all they did was they reported what they. I thought it was really worth bringing to the meeting. I thought it was really good. But basically, in this unit, I think it's King's Lynn, they were using Thrive on their intensive care and the emergency department. They decided to use it as their standard in obstetrics. And what they did was, if somebody came in for a GA, they just attach the Thrive in theatre and then try and pre-oxygenate them as long as possible with it and then get them off to sleep. And one of the things they did find was it was quite difficult to reach this 10 minutes in that situation. I can well imagine that it must have been quite difficult. But the least they did it for was 7 minutes. They still had SATs at 94, mean 98. So, well, actually, that's pretty good, isn't it? So, but it's quite a small number of patients, though. So it's the fact that you have to keep it on for 10 minutes is an issue, I think. Here's a trial that was being done on pregnant women, not that they were having a GA or anything. They were just giving them Thrive for three minutes before they intubated them, and they found that the end tidal oxygen didn't reach a very high level in 2 out of the 4 cases, and fell quite rapidly. So not that effective. You'd hope to do a lot better by putting a face mask on somebody, wouldn't you, really? So again, it's a personal view. I think what you need for a good pre-oxygenation is holding the mask on very carefully and checking for leaks and looking at the end tidal oxygen and forgetting about 3 minutes. And the stuff from the DAS guidelines, where it says you can now relieve the cricoid and do a bit of bagging, I think those are the advances. Unfortunately, they're not very sexy, are they? They're not, they're not like a nice bit of kit. And I'm very keen on bits of kit. Believe me, I'm a bit of a geek in that way. But I just don't see it as having a place in labour ward. It's too cumbersome. It's cost £70 a go as well. And so I think for your standard pre-oxygenation, it's not the thing. But you might have the odd case where it's useful. Isn't that right, Claire, in Rotherham? You had a case, didn't you? I think where there was a woman with severe respiratory, I think it was severe scoliosis, wasn't it? And she was on intensive care with Thrive going on, and they took her into theatre, gave her a spinal, and kept that on to maintain her oxygenation. Yeah, so I think for that, it has got a place. I think at the moment, I don't have a lot of confidence in it for obstetrics. Okay, so couldn't really leave without saying a little bit about enhanced recovery. Sorry about that. So I'll try and keep it as brief as possible. In case you've forgotten, which I'm sure you haven't, the key things of enhanced recovery are the multidisciplinary team, reduction of stress response to surgery, excellent perioperative nutrition, post-operative painkillers that don't rely on strong morphine-like painkillers, and rapid mobilisation afterwards. Now I'm guessing that most of you are already doing all that anyway. I think that's going to be the case. And in fact, so I should feel slightly bad now because this has got my name on it as well. But it's a systematic review that we did of the evidence about enhanced recovery. And actually, there isn't a lot of really high quality evidence that the things that we do are good. But the things that came out of it were this minimally invasive Joel Cohen surgical technique. Has anybody heard of Joel Cohen surgical technique? No? Hands up, anybody? No? Okay, so that's good because you're going to find out about it now. And early removal of the catheter, that came across well, and the use of post-operative antibiotics was a good thing as well. But a lot of the evidence is mostly low or moderate. So it's one of those things, isn't it? We've kind of done what we think seems like a good idea. And there's nothing wrong with doing that. That's a good thing to do that. But actually, it doesn't have a very strong scientific base. So what about this Joel Cohen incision thing? So here is a number of abdominal incisions, and you can see the fan and steel is the standard one. The Joel Cohen is slightly higher up. And what they do a small incision, and then they put their fingers in and dilate up the wound. I think they can put forceps in and dilate it up that way. They stretch the wound. They don't cut it as wide as it needs to go. And there's actually quite a bit of evidence about it as well. So because there was a review done by Cochrane, where they found that using this technique resulted in less fever afterwards, less pain afterwards, less blood loss, reduced duration of surgery, definitely in favour of that one, and hospital stay was shorter. I mean, that's a really hard endpoint, isn't it? Less hospital stay because of this particular incision. There's not a lot of work done on long-term morbidity or mortality, but you might think perhaps it would be better for chronic pain. That's one of the things, isn't it? Long-term pain after cesarean section. Maybe this incision is good for that. So I rather sort of sheepishly said to my obstetric colleagues, how about using the Joel Cohen incision? And they said, well, it's a small number of studies, Doctor, and you can't do it with scarring. If it's a repeat cesarean section, maybe that's true, I don't know. And actually, it's quite a very good way for the trainees to learn about bleeding is to allow them to do a big incision. Oh dear, I haven't put his name on, so that's good. Anyway, which I thought afterwards, well, how did I not question that when he told me that? Anyway, so, but I think that some of our surgeons are, because when I went to talk to the other surgeons, some of them were already doing it. And one of our particularly quick surgeons, I've seen him, he does a small incision and he goes like that with it and stretches the wound up with his fingers. And although it's an obstetric thing, it's important to us because of these benefits that it could potentially have. Now we produced these changes in Sheffield, and I'm just going to tell you a little bit what happened next because we've published some of them. And this is what we published. So you could see the next day discharge rate, it went up quite well to about 25%. So since then, this is the data after that. So that's the period of introduction, and this is a sort of QI type thing. Quality improvement, hopefully quite interesting as well. And you can see that that was the sort of couple of years that we were really pushing the technique, and we've not particularly pushed it too much after that. And you can see that what happens, it carried on going up, but then it's plateaued a bit now. Okay, so the blue line is the elective patients. But what it did, we'd never really said anything about the emergency ones going home the next day, but that's happened anyway. Even that, so this is a sort of crossover benefit. So I think a couple of things to do about that. It has benefits outside of the thing that you're doing, so that's a really good thing. But if you want to maintain that improvement, 2 years is a fantastically long time to push anything. I think it's really hard work. One of my colleagues was just telling me it took him 6 years to introduce REMI PCA, which I thought was amazing for Chesterfield. But you can see, perhaps if we revisit it and pushed again, we'd get an even better result. But because it's not bad, is it? 35 to 40. So that's basically it.
Does anybody have any questions for Dr. Wrench? Got the microphones.
Oh, okay.
Regarding the Thrive, I didn't know that we could transfer the patients. Is it possible to transfer on Thrive? Like if you say like pre-oxygenation prior to transfer to theatre?
Well, in that trial, they didn't do that. They only did it in theatre. They only did it in theatre. I think what you're saying is you need an enormous oxygen supply, don't you? And it would be, and all the rest of it. They did it in theatre.
Thank you, Dr. Wrench, for the interesting talk. As always, Enhance Recovery is my interesting project along with yours. But this question is about programmed intermittent boluses.
Right.
In your study, you showed that in your data, was there any difference in instrumental deliveries following introduction of intermittent boluses?
We didn't find one.
You didn't find that?
No,
okay.
We didn't find one. I think the benefits you're going to see will depend on if you have a unit that basically has an infusion regime with some small boluses, then changing the infusion to a bolus, that's going to make the biggest difference to you, I would say, looking at the literature. If you've got a regime with fairly generous patient activated boluses, it may not make that much difference. Just a little bit, but not much.
Thank you.